It's a single center observation done in Kilpa Medical College, Chennai, and I am publishing. Background. Basing eGFR and proteinuria have been shown to determine the outcome of IgA nephropathy. Oxford NEST scoring is a recent mathematical scoring to prognosticate IgA nephropathy independent of the clinical variables. NEST scoring has been validated in prospective studies in North American and Chinese population. And NEST scoring. NEST is an acronym for descendant hypersensitivity, endocapillary proliferation, segmental sclerosis or adhesion, and tubular. It has a maximum score of 5. The aims of our study is to assess the correlation of baseline serum creatinine, eGFR, serum uric acid, and proteinuria with the outcome of IgA nephropathy, and to determine whether NEST scoring correlates with baseline clinical parameters individually. And clinical parameters in both the clinical and laboratory parameters. To assess whether NEST scoring prognosticates IgA nephropathy. The fourth aim is to determine whether NEST scoring is superior to the baseline clinical parameters in predicting the prognosis. Materials in numbers. It was a retrospective study done in KMC Chennai. The case records of patients were undergone biopsy between June 2008 and December 2010 and included 245 patients, of which 48 were IgA nephropathy. Since 4 patients had lost to follow, we included 44 patients, of which 25 were males and 19 were females. The mean period of follow-up was 22.2 months, and we see that majority of the patients were in the 15 to 50 age, 20 to 30 and 23 to 31. At the end of the study, 19 persons had progressed and 25 did progress. To precisely define, progressors were those who had doubling of serum creatinine, development of ESRD, or initiation of RRD. And non-progressors are those who had stable creatinine or had improvement in serum creatinine during the follow-up period. The clinical variables that are analyzed are basic creatinine and eGFR, which was used analyzed during India formula, proteinuria, mean arterial pressure, serum uric acid, and serum triglycerides. And the pathological scoring was done using NEST classification by pathologists. And apart from NEST, other pathological features like presence, reduction technique, and arterial iron are analyzed. And these pathological features are correlated to individual clinical variables in both the progressors and the non-progressors. Use of SSK routines of that, and linear analysis was done by Peters and Pearson's correlation function. And multivariate analysis was done by box regression, logistic regression, and Kaplan analysis. This slide shows the distribution of eGFR in patients with progress. You see that average eGFR in these patients are 29.2, and it was significant in predicting progression. And in non-progressors, the average eGFR was 15.6 ml per minute, and the p-value was 0.005, and it was statistically significant in predicting progression. This shows the distribution of NEST score in progressors. The mean score in progressors was 3.16, and the p-value was 0.005. And the NEST scoring in non-progressors, the mean NEST score was 2.12, and the p-value was less than 0.005. And this slide shows the correlation between NEST and serum creatinine in progressors. The green color bar represents the NEST score. The correlation between the score and serum creatinine was not statistically significant. And similarly, in non-progressors also it was not statistically significant. And this diagram shows the distribution of NEST scoring in progressors. You see that around 60% had a score of 2, and the majority had a score of 3, which was 60%, and 20% had a score of 4, and 1% had a score of 5. In non-progressors, majority were in 3 and below. 36% had a score of 1, 24% had a score of 2, and 32% had a score of 3. There are none had a score of 5. This table summarizes the slides above, and we see that the mean serum creatinine in progressors was 2.7 milligrams, and in non-progressive was 1.4 milligrams. And using PAT test to predict prognosis, the p-value was 0.05. So the mean serum creatinine was not statistically significant in predicting progression. And using Pearson correlation coefficient for proton risk score, the mean serum creatinine was not statistically significant. The mean eGFR EGFR in progress was 29.29 mm and in non-progressive was 59.6 mm per minute. The mean EGFR was both scientifically significant in predicting progression as well as in correlation with total risk score. Urine PCR in progressive was 6.06 plus or minus 1.59 and in non-progressive was 2.16 plus or minus 1.12. Like mean EGFR, it was also statistically significant in predicting both progression and in correlation with total risk score. About uric acid, mean serum uric acid in progressive was 1.5 plus or minus 1.69 and in non-progressive was 5.8 plus or minus 1.65. So it had a statistically significant in predicting progression, it did correlate with total risk. So the histological features that correlate with the core outcome in our study are tubular atrophy in Mexico, presence, severe blood vessel decay, and arterial diameter. Results of this statistical analysis: in univariate analysis, nephrotic range proteinuria and low baseline EGFR and higher serum uric acid levels were associated with progression. The correlation between total risk score and renal outcome was statistically significant in univariate analysis. The T-score, the tubular score and presence are found to be individual predictors of renal survival in companion analysis. The control, low baseline EGFR, nephrotic proteinuria, and serum uric acid are individual predictors of disease progression. High total risk score at the time of presentation is individual predictor of disease outcome. High total risk score predicts low baseline EGFR and nephrotic proteinuria. Tubular atrophy and partial presence also individual predictor of renal survival. Hence, risk score is neither superior nor inferior in predicting the renal outcome in compared to EGFR and nephrotic proteinuria in our study. I would like to thank Professor Dr. Balaram, Dr. Randa, and all my colleagues for their cooperation. Thank you. Thank you all.
One person is having taken into account the treatment given to these patients to assess the outcome. Like 70 months.
Not much, because it was a only retrospective study.
That could also influence the outcome of this patient. Not all the clinician does go proteinuria and
Because it was a retrospective study, it couldn't match the outcome of the assessment treatment.
and also total risk score. You should have taken individual score.
The individual risk score didn't correlate.
Rather than taking as a
Apart from the T-score, the AES didn't correlate in our study. Because most of the patients had a GFR lower than what the original also said.
Those who 10 months, even should have given treatment aggressively rather than necessarily. M1 and even those more aggressive.
Yeah, but they didn't have any other partial risk or something to like warrant presenting. So, go with the
Following the establishment of plasma exchange as a gold standard treatment for GP syndrome, two large and small trials have shown that IV immunoglobulin has equivalent efficacy. IV immunoglobulin contains pooled polyvalent IgG extracted from the plasma of over 1,000 blood bottles. Its effect lasts between 2 weeks and 3 months. The dose is 0.4 grams per kg daily for 5 to 7 days. The special indications for IV is more in plasmapheresis group than IVIG. Conclusions: plasmapheresis and IVIG are found to be effective in the treatment of GP syndrome, and plasmapheresis is found to be a preferable modality over IVIG in our study. Thank the faculty of blood bank students for providing the blood products for plasmapheresis, and I thank Dr. Vishnuvardhan, Assistant Professor in Statistics, for doing the analysis of our study. Thank you.
Are less, that's why you have concluded this way, or do you have any other explanation to say that plasmapheresis is superior to IVIG?
Previous trials showed both are equally effective, but the number is also available to study is also sufficient.
How did you evaluate to go to this numbers? Plasmapheresis or IVIG? How did you select?
Actually, neurologists they explain patients how to go the patient, neurologist patient. And if there is any definite contraindication for any of the another one is selected, and financial basis also.
So it's not a randomized study, that's why the conclusion that we have got is contrary to what is the literature and what is the neurologist field. Both of them are equally effective, but your study found that plasmapheresis is as good as IVIG. Thank you. Dr. Shivakumar.
The plasmapheresis is definitely superior in terms of numbers also. If you see the Western data, the Cochrane outcome, IVIG and plasmapheresis are equally good. Not many studies have really proved that one is superior over other, because the stage has come in plasmapheresis, IVIG, Glenn-Barry. It is very difficult to do a randomized trial because two specialists with two egos are involved here. A nephrologist is never available to a neurologist, and neurologist doesn't want to come down to nephrologist. So, luckily our situation is different. We have very cardiac relationships. So, what we found is it is cheaper. Plasmapheresis, one. The second thing is, as he said, randomization. Here there is no bias in this study because both the things were told to the patients. Whatever they wanted, they got it done. So it is not that some patients are given IVIG at our own discretion and some are given plasmapheresis at our own discretion. No, it is the patient's discretion when the available literature is speaking on either side. So that is the data. So in this there is no bias, and definitely plasmapheresis is cheaper and it is definitely superior. But this problem will always be there because if neurologist says for this the treatment is no nephrologist, it will definitely affect the several aspects. So in institutions, what I suggest is those are practicing in institutions. It is incumbent upon us to impress our colleagues that plasmapheresis is definitely superior. The reason being, the long-term visibility, even if it is very minor, it is minor. A person who is going to be a sprinter will never